Abdominal distension. Abdominal distension is defined as the sudden or gradual increase in the size of the abdomen. Distension can be classified as intermittent, persistent, and asymptomatic or painful according to Cornelius. Abdominal distension may be due to fluid, as in the case of ascites, uroabdomen, and hemoperitoneum. And these can also be due to non-fluid causes, as in the case of air for bloat, tumor, fecal retention, fats, and the likes. There are also associated signs that can be linked to abdominal distension, and almost all of them are involving the gastrointestinal tract. These can include vomiting, diarrhea, abdominal pain, and also includes polydipsia, polyuria, polyphagia, and edema. Pathophysiologic mechanism of ascites. Similar to edema, two mechanisms involving ascites is determined. First, the primary event is the escape of plasma into tissue spaces with resultant hypovolemia and secondary renal retention of water and electrolytes. And second, the primary disturbance is excessive renal retention of electrolytes and water, leading to extracellular fluid expansion and transsudations of fluid from plasma into tissue spaces. For the general mechanism of ascites formation, more than one of the following are often present in the clinical cases of ascites. First of which is the increase in the capillary hydrostatic pressure, which is accompanied by increased capillary permeability. Second is the decreased colloid osmotic pressure of plasma. And third is the obstruction of lymph flow. And also, there is excessive renal retention of sodium and water. In abdominal venous obstruction resulting to increased capillary hydrostatic pressure, the protein content of the ascitic fluid can be used to determine the site of venous obstruction, whether it is post-sinusoidal or pre-sinusoidal obstruction. Post-sinusoidal obstruction of the liver results to production of high protein content, which is more than 2.5 grams per deciliter. Obstruction of intestinal lymph, which is pre-sinusoidal, produces low protein ascites and is less than 2.5 grams per deciliter. Abdominal masses can cause vascular damage and leakage of blood or plasma, resulting in high or low protein ascites. Paracentesis and fluid analysis is important to determine whether the mass is blocking the pre-sinusoidal or post-sinusoidal flow. Remember, less than or greater than 2.5 grams per deciliter. In cases of decreased colloid osmotic pressure of plasma, which is also called hypoalbuminemia, it must be very severe to cause ascites. Lesser degrees must be accompanied by mechanisms such as increased capillary permeability and increased capillary hydrostatic pressure to cause ascites. This is due mainly to the escape of fluid from intravascular to extracellular. Other causes of ascites also includes the presence of blood in the peritoneal cavity, which is also called hemoperitoneum. This presence of blood is said to be due to trauma or rupture of an hemangiosarcoma, or can be due to a rupture of an anorectic vessel. Other than blood, urine can also cause ascites, and the presence of urine in the abdomen is called uroabdomen, which can be due to rupture of any urinary organ. In the intestines, ruptured bowel can also lead to ascites. This is due to septic peritonitis, and it has signs of endotoxemia and septic shock. The diagnostic plan for ascites or abdominal distension by Cornelius. History and physical examination is important. On physical examination, percussion is done to observe for fluid movement. If present, paracentesis is highly recommended. Acquired fluid is used for fluid analysis which is used to rule out whether the obtained ascitic fluid is with high protein or with low protein content. Again, remember, greater than 2.5 grams per deciliter or less than 2.5 grams per deciliter. This is to locate whether the problem is pre-sinusoidal or post-sinusoidal. In percussion with no obvious fluid wave movements, radiography is indicated. In radiography with presence of fluid, the ascitic fluid is also analyzed, whether with high or low protein content. This is again to rule out if the location of the problem is pre-sinusoidal or post-sinusoidal. In radiograph with no evidence of fluid, the problem must be ruled out whether the cause of the abdominal distension is due to fats in obesity, fetus in pregnancy, GIT problems like gastric bowel dilatation, or due to organomegaly, and lastly, maybe due to tumor. Therapy for ascites. Treatment of ascites depends upon the case. Symptomatic therapy is best done by administration of diuretics such as furosemide and dietary sodium restriction. Paracentesis must be done in unresponsive patient. In patients with ascites restricting lung expansion and causing difficulty in breathing, paracentesis must be done immediately. For others causing abdominal distension, the treatment or therapy varies. For uroabdomen and hemoperitoneum, if severe, paracentesis is a must to relieve pressure in the abdomen. In uroabdomen, which is a medical emergency and not a surgical emergency, it is important to stabilize first the patient with IV fluid therapy and treatment of hyperkalemia. Installation of catheter or others for urinary diversion is necessary for stabilization to avoid anesthetic risk during surgery. In patients with hemoperitoneum, therapy consists of first, restoration of circulating volume by IV fluid administration, and second is maintaining and restoring of oxygen carrying capacity by giving blood products, and third is for relieving abdominal pain with analgesics, and fourth is arresting hemorrhage with vitamin K or antifibrinolytics. For the treatment specifically with penetrating trauma, surgery is required. In cases of abdominal tumors, it is important to assess first the patient and the tumor itself. The tumor can be located via palpation or using radiographs. If the assessment is done, then surgical removal is initiated. For hypoalbuminemia, the treatment is dependent upon the cause and must be determined. For the meantime, to prevent ascites formation and edema, plasma should be given. Septic peritonitis due to intestinal rupture is a life-threatening condition. This requires emergency stabilization of the consequences of peritonitis like shock. Immediate surgical correction follows, and antibiotics are a standard part of the treatment. That's all about abdominal distension, and thanks for watching.